show some onset, we're going to give TPA if the patient is a candidate. And we know about 30% of patients improve compare with about, I forgot the exact number, about 12-13% was in the placebo groups improved neurological functions, but that was not an immediate improvement. So that study was compared with 90 days. So when they compare with 90 days, they find out there's 30% of patients, which is a significant higher than the placebo group, has a benefit from the TPA given within 4.5 hours. So that's why we stick to the 4.5 hours TPA because based on the 90-day improvement in neurologic function. Of course, there's a side effect. So you can see there's a high risk of bleeding, especially symptomatic ICH, intracranial hemorrhage, about 6.4% in the treatment group. Here I think Sharon preached the slides. I think she said a tenfold increase for 0.6% the placebo. I'm not sure that was tenfold increase. I think it's probably 5 to 6 times increase of the. I think placebo is around 1.1 or 1.2% of the symptomatic ICU. But I can check back on the numbers. But I remember about a 5 to 6%, 5 to 6 fold increase of the symptomatic ICH in the TPA treatment group. So whenever before you give TPA, normally we also get their oral consent or tell them the risk and benefit. But this is the standard treatment right now, so we don't need before we have to get a consent, family or patient get consent before we give TPA. But nowadays we don't need to get consent for the TPA because that's a approved standard treatment. But we still want a patient know that there's a certain risk. However, the benefit is more than risk. That's why we're using the medication. But for certain patients, they do have contraindication for the TPA. For example, recent trauma, recent surgery, recent GI bleeding, and platelet was low. We're not going to give the TPA because that's contraindicated to prevent this high risk of bleeding. Mortality rate are between the similar within 90 days, so that's why we give the medication and we compare the neurological function and mortality in the 90 days. TPA dosing, this is the approved dosage was the 0.9 milligram per kilo. However, the maximum dose is 90 milligram, which is according to 100 kilo. So if the patient more than 100 kilo, you will give the same dose, 90 milligram. So 10% will be given as a bolus, so one single dose IV injection within 1 to 2 minutes. Another 90% will give it as IV transfusion, IV infusion over an hour period of time. So by mixing the TPA, you just 2 bottles, one is water, one is the powder. So just punctate this 2 bottles and with the upside down with the water bottle, allow the resolve the powder and gently swirl and give through a dedicated line. At the end, you give another 50 cc of the normal saline to get all the TPA get into the body system. So this is more relevant to our team, Caradigm team, which is the post-TPA monitoring, which we want to have this vital signs and neural status, which we use as a modified NIHSS score. So every 15 minutes for 8 times, which is about 2 hours, and every 30 minutes for 6 hours, which is about 3 hours. 6 hours, sorry, 6 hours. So it's 8 hours now, and then hourly for 16 hours, totally 24 hours. After TPA treatment, we want to get this documented and monitored. And blood pressure goal, basically after TPA, the goal is less than 180 over 105. So if more than that, we need to give some Labetalol IV, or even we start nicardipine or Cladribrex IV drip to maintain the blood pressure within the goal. if during the transplantation or during the IV TPA injection or infusion, there's any neurological changes, we can stop the TPA because we want to make sure if there's any bleedings or side effect from bleeding. And we stop the TPA and we can get an immediate CT scan to make sure there's no bleeding. If there's no bleeding, actually TPA can be continued afterwards if still indicated.
I just have a question.
Yeah.
So CareLink's often involved in the transport portion where the patients receive the TPA bolus and they're receiving the infusion.
Yeah.
I had two questions. Can you speak to us a little bit to other signs or symptoms that we might experience that would be adverse reactions to TPA where we'd want to stop that infusion?
Right.
And then also choice of antihypertensive drug if we're calling for orders with the patient with elevated pressure on TPA.
Right.
How do you decide if you want to give nicardipine, labetalol, or clefprex to those particular patients?
Sure. Very good question. So let me just go through here. So to answer your first question, I think that's good information. So complication with TPA, number one we are really worried about is intracranial hemorrhage. So that will be normally presenting with severe headache and because the bleeding, so there's intracranial pressure could be going up. So actually blood pressure, if you check, sometimes will be going up too. And nausea, vomiting, and mental status changes. Become more confused, loss of consciousness. That's all the symptoms of the intracranial hemorrhage. Another one is shown in the picture, which are more of the angioedema, which is common. I mean, not that common, but here I think that we have how many percentage? Probably 1 to 5% of patients may have this angioedema. It can happen bilaterally, kind of a systematic response, but also can happen on one side, which is kind of in this picture only on the right side has eyelid swollen, lips swollen. So those are symptoms kind of reacting to the TPA allergic reactant, and also has airway obstructors or difficulty breathing, and sometimes I think the last one is anaphylaxis, which is a more severe type of allergic reaction. Patient could have shock, altered mental status, passing out, those very severe reactions. Treatment for those are more of Benadryl, Solomedrol for those. If really patient had airway problems, we need intubation to helping out for the stridor, for the difficulty breathing. But normally it's temporary. It's very after the TPA resolves. The TPA phase are really about hours, in the hours or sometimes 24 hours after TPA wears off. I think those are symptoms gradually getting better. Patient normally very easy to extubate after TPA, after the reaction. And another thing is just
I had asked about choice of
antihypertensive. So basically, according to the guidelines, so basically whenever there's a blood pressure high, we use labetalol first. So I think that was quick onset and quick action. Better than another choice, which is hydrolysine. Hydrolysine a little bit, sometimes causing what we say is increased intracranial pressure. So we don't want to use hydrolysine as the first line. But if the patient has bradycardia, say if the only heart rate is 40s, 50s, I think the hydrolysine probably is the number one choice for the IV injection. However, if you give, according to the guideline, they say you can give a labetalol, you can repeat one to see the blood pressure. If still not able to adequately control, and then, or at the meantime, you prepare for the nicardipine for the clefprex. So those are two medications that are both are calcium channel blockers. But nicardipine is compared with clefprex. I think clefprex is more quick onset, quick offset. So the action is more quicker, faster, and also the the effect is faster too. So for clavipride, you need a frequent adjusting the dosage to maintain, but the action is very quick, better than nicardipine. Another thing is that nicardipine is a volume. So nicardipine is a huge volume that only has, I think now we have double strength of the nicardipine, but normally they go through, if you give 10 milligram per hour, there will be 10 cc per hour, this infusion. So normally it's a large infusion for the nicardipine. But for claviprex, the dosage and the concentration of the medication, so the volume are small. Volume is small, so I think it's good for those patients has congestive heart failure or has other pulmonary edema patient that will has a more, or sometimes end-stage renal failure on dialysis. Those are for the IV fluid volume control. The claviprex is much better. But nicardipine is the first approved by the FDA for the stroke treatment acute. So nicardipine is used early. So many times we still using nicardipine, and the ER cardines are more aware, has more awareness than the claviprex. But now the new guideline also put on claviprex in the guideline. So right now both medications are available for the blood pressure, but we tend to prefer, if you have a claviprex, we prefer the claviprex as the #1 choice.
We don't stock that on.
Yeah, yes. So I think that's probably because nicardipine was used way earlier before and has been standard for many years. So that's, I think, still very easy to get and easy to use. But recently, I think claviprex are in the guideline. We are using that more and more. But that was more the bottle of the claviprex is more propofol is liquid form of the medication. So so for those, some ER physicians, some critical care physicians don't want to use combined with propofol because they think there's too much lipid metabolism. They have to watch for the triglyceride every day or something. So there's something, but however, we have been using with even with propofol, we didn't find any problem so far. So our first choice, you have a claviprex. I think claviprex is better than cardine in terms of action, in terms of off action. Yeah. So we can modify the NIH score. You all know that's very good. For the transport, so basically, if TPA has been given to the patient and we transfer to a higher higher level care of hospital, we call it drip and ship. So that's, I think you all do in Carolyn is very important, very good job. So basically, when during the transplantation, you may consider active cold stroke. If not IR candidate, patient direct admit to neuro ICU or stroke unit. Normally they will have a bed assigned. However, if there's no bed assigned so if no ICU bed ready for the patient will go to the ED. So we want to delay the transportation. The patient can go to the ED if there's no ICU bed available at the time. But if there's an IR candidate, interventional radiology, or we call it endovascular treatment candidate, then you go to ED at the time, or directly go to interventional radiology suite to do the procedures to do the mechanical thrombectomy. Blood pressure goal, basically, we see very commonly the stroke patient has higher blood pressure. Actually, for the ischemic stroke, that